I have the session Fillers in Reconstructive in Cosmetic Gynecology. I have no financial relationship to disclose and no known conflicts of interest. So, the fillers are regulated by FDA, Federal Drug Agency, as devices. It's mean like implants rather than drugs or medicine, thus making the regulations governing product safety and use different from those for medications. Fillers represent a popular non-surgical method because their application seems to be simple and safe. In 2018, the estimated number of injectable fillers procedures in the United States reached 2.7 million according to the American Society of Aesthetic Plastic Surgery. Hyaluronic acid gel fillers are among the fastest growing non-surgical procedures, up 58% in 5 years, respectively. Of course, the biggest group which use fillers are female, not males. The males and about several percentage. So fillers may be classified as temporary or permanent. Temporary fillers are biodegradable and metabolized or otherwise degraded by the body. The longevity of their aesthetic enhancing effect is dependent on the type and amount of a filler, treatment location, and injection technique utilized. FDA-approved temporary fillers include collagen, hyaluronic acid, and calcium hydroxyapatite. Polyl-lactic acid, PLLA, is not technically a filler, as it relies exclusively on its biostimulatory properties to incite collagenesis. However, the results of this volumizing agent are not permanent, allowing it to be classified as a temporary filler. Polymethyl methacrylate microspheres are the only permanent, non-biodegradable, biocompatible synthetic filler approved by FDA. In gynecology, we mainly use hyaluronic acid fillers. Hyaluronic acid filler was approved by the FDA and entered on the market in 2003. These are non-permanent injectable fillers. Hyaluronic acid fillers are classified as non-cross-linked or cross-linked. Cross-linked fillers are classified as monophasic or biphasic. Monophasic may be further categorized as monophasic mono or polydensified. The biphasic and monophasic monodensified fillers presented greater intradermal durability than did the monophasic polydensified fillers. Crosslinks are intermolecular bonds that enhance the stability and durability of clinical implants. The most commonly used cross-linking materials are PAG, this means polyethylene glycol, and BDDA, which have been refined to reduce endotoxin and the risk of sensitivity. In our study, we use hyaluronic acid hydrogel cross-linked with polyethylene glycol, 28 milligram per milliliter. The fillers are biomimetic. No immunoreactions are present. Here is the indications in reconstructive and cosmetic gynecology, like the hypertrophy or atrophy, vulvovaginal syndrome, which means itchiness, dryness, feeling of tautness and heat dyspareunia, looseness and scars rebuilding, postpartum extendedness of entrance to vagina, and its lumen to stretching of mucosa. Atrophy of the vaginal mucosa, e.g. after delivery, menopause. G-spot augmentation and asymmetry, lipodystrophy, skin laxity, and ptosis. The last one in the green circle, I have written by myself SUI. This means stress urinary incontinence. It's not now covered to these indications, but this is the thema or method which we use and start and think about in future could be the first method in use for use. We call this method transvaginal suburethral filler repair. Only 2 studies with usage of hyaluronic acid are in systematic review of literature for labio majora augmentation from December 2017. I think that you all know what stress urinary incontinence is. I would like to make here some joke. I don't know if you understand or not, but I wanted to tell hope so out of earshot. But my wife tell me, don't say this because I am from Czech Republic, Prague, and maybe the auditorium will not understand this joke. I don't know if you understand that. I hope that you only heard about stress urine incontinence and nobody have some problems with it. So here I will not discuss what the National Institute for Health and Care Excellence recommends to do in guidelines. In summary, you see it on the following slides. On shortly, in assessing urinary incontinence, you need to take a history taking and physical examination, where you need to categorize women strictly to groups if this is stress, urgent or mixed urine incontinence, mixed urine incontinence with predominant stress or predominant urgent. On this classifying depend what you will do in the next. But I think you all know this. I will not tell. I will not tell more about. So you need to do urine dipstick testing, symptom scoring and quality of life assessment, and bladder diaries in line with new guidelines from April 2019. You need to do assessing residual urine, PET testing, other tests for urethral competence, cystoscopy, and imaging like MRI, CT, or X-ray. Also, do not perform urodynamic testing. Why the committee made 2019 recommendation? The evidence did not show any benefit from urodynamic testing to assess stress urinary incontinence of stress predominant mixed urinary incontinence in women who have demonstrable stress urinary incontinence before primary surgery. The committee concluded that urodynamic testing is not necessary for most women in this situation. However, based on their experience, the committee agreed that urodynamic testing can be beneficial if the diagnosis is unclear or if the woman has symptoms of voiding dysfunction, anterior or apical prolapse, or history of surgery for stress urinary incontinence. How the recommendation might affect practice? The recommendations are likely to reduce variation in practice, which is largely caused by uncertainty about the clinical value of urodynamic testing before surgery. They are also expected to reduce the number of women having urodynamic testing before surgery and avoid unnecessary use of a procedure that some women find unpleasant. Here is briefly the surgical management, what again these guidelines recommend you, that you must offer to women all the procedures. If women cannot have procedures like colposuspensions or autologous rectus fascial sling or retropubic mid-urethral mesh sling, so you can offer, and they can choose intramural bulking agents. So in follow-up after surgery, you offer them appointment within 6 months for all women after procedures to treat stress urinary incontinence. For women who had retropubic mid-urethral mesh sling surgery, the follow-up appointment should be included with vaginal examination to check for exposure or extrusion of mesh sling. And here is what we do. This is my brand new name, transvaginal suburethral filler repair. We do in my settings all what is recommended in these guidelines. What I have speak before about accessing urinary incontinence and about surgical of stress incontinence, and only one thing we don't offer to patients bulking urethral transurethral agents, and we offer them transvaginal suburethral filler repair. If we offer them this, so we can do this when is possible, or possible if we manage the stress urinary incontinence, if alternative surgical procedures are not suitable for, or if this is acceptable for women. We explain to women that maybe temporary injectable materials, not permanent, that we can repeat injections, and that now, till this time, no evidence of efficacy in the literature, only our assumption and our ongoing documented experience and the level of satisfaction of women after the procedure comparable to other surgical procedures listed above, and the effects could wear off over time. There is no evidence on long-term effectiveness and adverse events. If a suburethral filler is injected, we give the woman written consent and information about the bulking agent, including its name, manufacturer, date of injection, and injecting surgeon name and contact details. In the follow-up, we do vaginal examination, ultrasound, satisfaction rate and evaluation of subjective feelings post-procedure, 1 and 6th week post-procedure, and then in follow-up, we in our design we will follow a women 5 years from the baseline, from the procedure, in all 6 months. So our assumption is based on a study by Petros and Abenstein that urinary stress incontinence is caused by collagen loss in the pubourethral ligament, and the implanted in the exact position of pubourethral ligament would reinforce it and cure SUA. Here are 2 closure mechanisms: distal urethral and bladder neck. In animal experiments between 1987 and 1988 proved that a collagenous neoligament could be formed by implantation of a tape. And we know that the hyaluronic acid, the hydrogel cross-linked with polyethylene glycol used in our study is biomimetic filler and no immunoreactions are present. Depending on and in line with all these already proven processes, we have done 22 completely new, minimally invasive and very patient-friendly, time-saving, cost-effective procedures from March 2016 until now. The last patient I have done procedure 10 October. So I have not seen her in 1 week because I'm here. So as I will go at home back, so I will check up her, but not in 1 week period in which we have in this design. The results are more than excellent in the current time horizon. The level of satisfaction and effectiveness of this method is very high. We have not any adverse event until now. 2 patients were lost from follow-up. This is the. This is so small. I see. This is the red here, lost follow-up, and the second one lost follow-up. This second one lost follow-up because she came after 2.5 months back to us and tell us that she have problems with not so good feeling by intercourse, like her and her partner, and she won't take out the filler. Nobody till this time take out the filler. We have tried this. We have evacuated with the same method how you insert the fillers. You insert the fillers with cannula the best because you need to avoid to emergency about bleeding and about take the filler to the vessels because in studies you can see that are very adverse event about embolism, lung embolism, but this is from dermatology, not from the time from gynae. So, we took out this filler, and then these patients will not come more to us. She called us only. She told us that everything is okay, everything is fine, but from this time we have not seen her. This is from 2021, November 2018. So only these 2 patients, no adverse event at the time. We initially set the time for observation up to 5 years, 6 months periods, what I have told before a while. We monitored the satisfaction and effect of the method according to the subjective expression of the patients on a scale from 0 to 100%, together with vaginal ultrasound, where we evaluate both the support of the urethra using the abdominal press and measure the size of deposited hyaluronic acid. The results so far show that in most cases, the bearing has not been reduced so far, and the urethral support in its distal part remains the same, created as knee or some curve, that the urethra isn't in the direct line and is curved, and with hyaluronic acid. This is similar to when it is necessary, for example, to bend and break the water in the garden hose. The less the water flows when we stop in the hive, we expect a similar effect in the case of the applied hyaluronic acid. When the front and back part breaks and the fore middle part remains elevated by the area of the applied hyaluronic acid. The lack of reduction in the area of hyaluronic acid applied is attributed both to the biochemical and biotechnological aspects. Crosslink, slow release of calcium hydroxyapatite, and hence to a very reduced degradation of hyaluronic acid itself, and increased production of both collagen fibers, type 1, and elastic fibers. So both the bulk and regeneration process is maintained. Conclusion. Fillers are an integral part of reconstructive and cosmetic gynecology. Our developed and prospectively monitored use of fillers containing hyaluronic acid, polyethylene glycol, PEG, cross-linked in women with stress urinary incontinence has very promising results, showing that they can be used as a first choice in women with stress incontinence, grade 1 to grade 2, without the need for other more invasive approaches. Of course, more data together with other studies are needed to confirm this assumption. Thank you for your attention.